Thank you so much. This is my 7th year moderating Convene, and there's a lot of fun parts to it, but this is really the fun part. Being in front of all of you and the people that are joining us online, so hello to all of you as well, and being able to not only curate the speakers that we have, but probing a little deeper on what their ideas are, what their thoughts are, what their predictions are for the future. So our keynote speaker this morning is from Microsoft. I will introduce him in just a moment. But I'll start by saying that the founder of Microsoft, Bill Gates, has been on the speaking circuit for the last few weeks or so. And he was recently on Jimmy Fallon, along with other shows. And he said something that felt bittersweet to me. And that's that he said that the work week within 10 years will go down from a 5-day work week to a 2-day work week. So who's up for that? I'm definitely up for that. I'm up for that. And the bitter part of that statement is that because he believes that within that 10-year period, AI will replace most of what humans do in the workplace, and it will primarily and most significantly affect healthcare and education. And the reason that he said that is because this is something he never imagined when he was creating the beginning of Microsoft in his garage. He never imagined that computers would create free intelligence. And that is the world that we are in. So the issue is not whether that will happen. It will happen. But there are questions about how it will happen, and what we're here to talk about today is how we can make it happen responsibly with the highest impact and the least harm. And the other thing that we have the opportunity to think about is how do we not only survive being replaced by AI, but how do we thrive? How do we get to the next level as human beings and add even another layer of what it means to be human? So really looking forward to today, really looking forward to some thoughtful conversations. And with that, I will introduce our keynote speaker. Dr. David Rhew is the Global Chief Medical Officer and VP of Healthcare at Microsoft. Started with an M. He serves as an adjunct professor at Stanford School of Medicine. He holds 6 technology patents that enable authoring, mapping, and integration of clinical decision support into electronic health records. We had dinner with David last night, and he was telling us that when he was entering the world of computer science as an undergraduate, he was somewhat discouraged to take that path. And he did it despite the fact that it would be a distraction a little bit to him pursuing a pre-med education, but because he thought it was so fun. He has been recognized several times as one of the 50 most influential clinical executives by Modern Healthcare as recently as this last year. He has his Bachelor's of Science from the University of Michigan, an MD from Northwestern University. He completed an internal medicine residency at Cedars-Sinai, did an infectious disease fellowship, and of course now is in his global role at Microsoft. Welcome to the stage, Dr. David Rhew.
Thank you. Well, thank you all. It is a real pleasure to be here. I think one of the most common questions I get asked is, what does the Chief Medical Officer for Microsoft do? And in fact, my mother would like to know the answer to that. I think the best way to describe it is I'm a bit of a translator for many of the things that we see today that are happening on the healthcare side, which is oftentimes a very complicated, siloed area, but then at the same time we're seeing a significant amount of transformation on the technology side, with especially AI becoming one of the most valuable and potentially important tools that we have. And so understanding how we can apply the technologies in a complicated workflow is what I oftentimes try to do, not only for Microsoft, but also for the clients and partners that we service. And so how did I get to this point? Well, I think a little bit of it was in terms of my training. I was a computer science major when I was an undergraduate, and in 1988, my thesis was AI in healthcare. So I've been thinking about this for a while. It actually was something that I don't think at the time there was a whole lot of basis for my thought. A lot of it was what we call hallucinations. But I do think that many of the things I was hoping for have come true. The ability for us to leverage technology in a way that makes our lives easier, that allows us to be able to do things that traditionally could only have been done by extreme experts. And as we've gone through that process, or at least I have gone through that, I've come to realize that this whole concept of AI has evolved from what I used to think of it in 1988 to now what we see of it in today. And I thought it might be worthwhile for us to just kind of reflect back in terms of like what that evolution has looked like, and even going beyond or back further beyond 1988 to the 1950s when the term artificial intelligence was first coined. It was coined in the context of a computer acting very much like a human. And we have now seen that we can go well beyond this concept of algorithms or if-then statements to now incorporating this into ways that the computer can learn from the data sets, it can learn from its mistakes, and it can ultimately become an evolving type of technology. And so this concept of machine learning tied to AI has become one of the areas that I think has become extraordinarily valuable. Now, what we have done in some cases is we've undervalued or underappreciated the transitions that have occurred with AI ML, because we can do things that, as I said before, only a human could have done. We can take a voice conversation and convert that into something that would be usable in a clinical note. And that can be done automatically with the AI. It's something called ambient clinical intelligence. And that's leveraging some parts of AI ML and then some parts of some of the newer types of AI. And what we have realized is that we can take unstructured forms of data as well as structured forms of data and convert them into things that are understandable. And I think that progress has become something that has been moving along rather quietly. Most people have not seen that until more recently. And part of the reason is because we never really thought of how this could be used for consumers and how for individuals. Now, we had certain things that we would see occasionally, like with GPS, and we would have an ability to have a voice where you could talk to your phone and it would maybe talk to you and give you some answers. But it was never at the point where we felt it was as good as what a human expert could be. Well, now we're starting to get to the point where we're thinking that it could not only match what a human could do, but potentially exceed human capacity. And large part of it has to do with the fact that we started looking at the way that the data sets were organized, and we realized that there was something called a neural network, where data points could actually be clustered together, and because of that clustering, because they're so interrelated, we would mathematically put certain weights on them, and that would allow us to be able to then determine what that next likely concept was, or that next likely word, or that next likely pixel. And by anticipating those interrelationships that were already present within these neural networks, we then identified this new category, which was really deep learning, but then going into the generative AI piece, which is that prediction of that next word or pixel and concept. And while initially most data scientists and computer scientists didn't think this would be as dramatic, but it actually, when we had very large data sets, started doing things that we hadn't anticipated. And that was extracting knowledge from these systems that we had not even realized were possible. So that was going on, and I think many people started looking at that as being, sort of transformative, but most of the world didn't know what was going on until something else happened. And that was that we put a natural language interface in front of this reasoning engine, and because we had that natural language interface, anyone, anywhere in the world could ask this reasoning engine a question and provide some of a query, and it would come back with a response in your language at your grade level that was understandable. And then you could have a conversation with this agent and allow it to be able to extract further information. And that was transformative, because then at that moment, we democratized all this information. And that's the reason why we're starting to see such a tremendous amount of interest in AI, because it's not just for the data scientists, but it's for all of us. And so as we've been thinking about that, I think one of the things that we've come to realize is that the artificial intelligence is moving at an astronomical pace. In fact, one of the key messages is that what we see today is unlikely going to be what we'll see 6 months from now or a year from now. And that's the problem when we see studies come out or when people analyze it and they draw assumptions about what AI is, because that was at one snapshot in time when the reality is it's much better and it continues to get much better. And so that's why you've got people that are spending a lot of time looking at AI and trying to figure out, is this something that we are able to harness and leverage? And literally, by the moment that you start implementing it, you've already got a new model in place. And so this has become one of the interesting things that's been going on. But the other thing that we've seen is that there's a significant amount of infrastructure that's required to run the data, to run the models. And that infrastructure has also progressed to the point where we have large enterprise systems that support a lot of these activities. So if you think about like what companies like Microsoft does, is we think a lot about both sides of it. So think of AI as a coin. On one end, you'll say your heads, you've got the AI models, and then on the tails, you've got the data. And you need the data to actually train the models, and you actually need the models to be applied on the data. So there's actually this interrelationship between data and AI that we sometimes just focus on the AI, but we don't realize that the data is a critical part. Now, the problem is that a lot of the data sets are oftentimes messy. They're incomplete. They're not representative of larger populations. So these models that come out from the data are very narrow, limited, which could be okay if you're trying to ask a very specific question, but oftentimes our questions are very general, and we want it specific for a certain population. So what we really do have to think about is how do we create data infrastructure that supports the training of these models in a way that you have large and diverse data sets, but we also have to do it in ways that are privacy preserving. A lot of times organizations and individuals don't want their data sets to be brought into one central repository. Cybersecurity is a big concern because a lot of times these data sets are brought in and there's an attack, and then all of a sudden all of that's leaked out. And so we have all these concerns about how we better manage data, but that's the reason why you've got enterprise organizations like healthcare organizations that think a lot about this and that are now trying to find ways to create models where we can harness all that information. So that's like one component of the data. And if you think of it in terms of a tech stack, that's, I'll say, one of the base layers. On top of that is the fact that there's a tremendous amount of information that is coming in, and it's not all the structured information that we see in databases, but we're talking about things that just will completely blow up the number of data sets that are required. We look at the human genome, we look at all the different types of biomarkers, we look at all the different types of forms of information that are unstructured, whether they're pictures, images, whether they're voice. These are all the types of new modalities that are now representative of information that has to now be stored and managed. So now we have a storage and capacity issue and a compute issue. And so now we're starting to look at, like, do we have enough space? And this is part of the reason why cloud has become such an important component of how we think of AI. But also, do we have enough compute power? And that's where there's a lot of attention on chips. And so now there's like multiple different players that are part of this ecosystem. And then we start getting into the actual data sets themselves. And I think if I were to talk to most people, we think of the data sets as being things that are on the internet or perhaps in known data sets that are out there. But really what we're talking about are things that are very specific for certain domains. And in healthcare, we have some very specific requirements because a lot of the data already is organized based off of standards such as HL7 FHIR or OMOP. We have to understand that these are the types of ways that current data systems communicate with each other. So we actually have to do a lot of translations and transformations of these data sets into things that are understandable, and so we can allow for more interoperability. And so there's another layer that is on top of that. And then we put on the AI layer. And the AI layer is also evolving, because I mentioned many different models, but oftentimes it's a combination of multiple different models that are happening all in sequence or in a way that it makes sense. So I'll give you an example. If I were to go into a typical clinic today, a doctor traditionally talks to a patient, and generally speaking, the conversation is, tell me how what brings you into the office. And then the doctor turns to the computer and starts entering things in. And usually it's like occasionally looking over their shoulder, and that's traditionally how the conversations go. Well, with AI, we now have an ability to just have that conversation, and then in the background, this computer is acting like a scribe, and then as soon as you're done, the note's written. Well, how did that happen? Well, there's actually several steps, and this is what we often have to do. We have to break it down into the key steps. Well, the first thing that's happening is the computer is trying to figure out who's talking. So it hears a voiceover on this side, says, okay, well, this person's talking, and maybe there's two people on this side, so now it's got to figure out, okay, it's person one, person two. And then they want to understand, when a person keeps on talking, what are the words that they're saying? So that ability to find who's speaking and to capture those words is what I'll call the traditional AI ML that we had talked about previously. Now what we're trying to do then is we want to understand what those words mean medically. So there's a certain mapping to certain terminologies, again, SNOMED and all the other types of terminologies. There might be LOINC codes. And so that mapping is oftentimes done automated through AI ML. Now we want to get into the note. And this is where the generative AI has become really valuable. So generative AI does three things really well. It can find information, it can synthesize it, and it can format it. And in this case, it's synthesizing it and formatting it into the form of a clinical note. And so now we've leveraged generative AI for this. And then the last piece is we want to integrate this back into the medical record, which is sort of another traditional technology, but maybe not so much AI, but more traditional integration. And so what we've done is we've actually stitched together a series of different AI technologies as well as traditional technologies to create a solution that seems very seamless, but because one of the big new innovations is the generative AI, it oftentimes gets classified as Gen AI, but it really is multiple different AI models. And I think that's what we're now starting to realize, that AI is more of a portfolio of different types of technologies that we have to understand how to best put together to be able to apply it into a real-world setting. So that's one of the things that's happening in the background. Okay, so with all of that, it now gives us an opportunity to start thinking about how can we leverage the data sets and the AI models to be able to solve some real important problems. So what would those problems be? Well, if you were to ask the Health and Human Services group, at least as of today, the strategic plan has been to focus on 4 areas. And I think these 4 areas are probably representative of what most people think are very important areas for AI to have a role. And the first is, can we innovate and do things that would have been much more difficult, if not impossible, for humans to do, and have AI take care of that? So that would be the first category, so AI innovation. The second is, as we're doing it, can we foster trust? Can we do it responsibly? Can we ensure that what we're doing people feel comfortable with? And so this gets into this whole concept of trustworthy AI. The next one is, are we doing it just for those that have access to the technologies, or can we somehow democratize this so that everyone has access to this? And we're talking about people that live in rural America, the people who live in underserved communities, people that are not tech savvy, people that don't have internet. How do we make it available and democratize it for them? And the last is what we just heard about earlier. There's a number of individuals that actually have to utilize this. So how do we empower a workforce so that they can actually properly utilize it? So these are 4 categories that I'm going to very quickly go through and talk a bit more about some of the things that we're seeing broadly, and hopefully this will give us an opportunity of understanding what the state of the art is as of today. So let me talk a bit about healthcare, because healthcare is not a system that really works well for everybody. And we know this because we see these gaps in care. We see our assessments of like the quality of care, not reaching the standards that we were used to. And in large part, it's because healthcare today is very reactive. What happens is a person has a symptom, they go to a clinic to have an evaluation, they go to an ER or urgent care, they go to a hospital, they get a diagnosis, they get a treatment, and they're put onto a certain plan. Okay, so oftentimes when you're in an ER or an urgent care and you have these people come in, one of the things that clinicians always say is, I wish you would have come in earlier. I wish you would have done something differently. I wish you would have taken better care of yourself. I wish you would have taken your medicines. I wish you'd have done all these things. And we would have always said, well, what's our strategy for proactive care? Well, typically it's, we're going to give you information about like what diseases you should be aware of. We're going to give you information about healthy lifestyles. And we're going to tell you, here's a bunch of things you can maybe do to track your own health. And maybe then we'll do some vaccination programs and some screening programs for cancer. That's literally our entire arsenal of how we do preventive care. Well, we have a new tool, and that tool is AI. AI can actually be applied across very large populations to completely change the whole paradigm of what we think of in terms of screening and allow us to move upstream. So I'm going to give you several examples of how this could work. So let's first think about that scenario. When people come in to see you or see a clinician in a clinic, that is a very small subgroup relative to the total population. There are many individuals that have the disease, that are at risk for the disease, I should say, but don't realize it. There are many individuals that actually have the disease, they're undiagnosed, but they don't even realize that. And then there are many people that know they have the disease, but they don't realize it's progressed to the point where they actually need to have treatments or they need to change their plans. And that's the group that we wish we could actually identify and bring in. But that's unfortunately the group that doesn't come in until it's too late. Well, if we can envision a scenario where AI is applied to this other group that didn't come in, we may potentially be able to not only have a direct impact on their quality of care, but potentially be able to reduce costs from an overall system-wide perspective. So let me give you an example of an initiative that will be launched very soon in about a month. And it involves screening the entire US population for a chronic disease by leveraging something that every one of us has done, which is get our eyes checked through a routine eye exam. When we get our eyes checked, traditionally, I mean, you can use the standing a certain way, looking at the eye chart, but there's also a machine, especially if you're going to get your glasses, and it's called an OCT machine. And that OCT machine is one where you put your chin on it, you get the lenses come over, it says is it better or worse, they flip through the different things, and ultimately there's an image that's taken of your eyes and it's stored on the machine. Well, one of the things, that image is extremely valuable because it captures it at the submicron level, the surrounding structures, the nerves, the blood vessels, and when you apply AI on top of it, you can identify pathology. So we've already seen this. There's actually, in the area of diabetes, over 21 studies that have been published that have looked at whether or not we can identify diabetic retinopathy using these images. And some of them are OCT and some are through what's called fundoscopic exam, which is essentially, imagine having the doctor use that machine or that little device and they look in your eye. There's also iPhone applications that can do the same. So these fundoscopic or OCT are opportunities for us to capture that. So diabetes is one area that we've actually seen a significant number of AI, and it works better than most clinicians. In fact, the overall sensitivity specificity in the meta-analyses is around sensitivity around 91%, specificity around 88% for diabetic retinopathy. To give you an understanding, most humans are around 80%. So we've got technologies that are working really good consistently and can identify that. It's also FDA cleared, it's got a CPT code, it's a lot of really valuable advancements. But it's not just diabetes. We actually see the significant amount of the same image where you could apply AI to identify cardiovascular disease, so looking specifically at the arterioles for calcifications. Think about like those calcium scores that people get, they get the CAT scans. I mean, we're looking at it through the eye. It's like the portal into your entire body. Hypertension, we can look at a variety of different ways. even chronic kidney disease. I gave a keynote at the American Society of Nephrology, and I shared a study that was published in Nature within this past year. And what they looked at in this study was individuals that had a significant decline, or if you look in the eye, you'll see there's something called a choroidal and retinal membrane. And then as the kidney function declined, the membrane thinned out. But then here's what's really interesting. These individuals got transplanted, so their kidney function restored back to normal, and the membranes returned back to normal. What was happening in the eye was actually reflective of what was happening in the glomerulus. It was an extraordinary kind of concept that the eye was actually representative of what was going on in other parts of the body. And that's actually, as we think about these diseases, whether it's kidney disease, heart disease, they're not really just specific to a certain organ. They are systemic diseases that just happen to manifest in these areas. And so you can find what's going on, whether it's the arterioles, the nerves, in other areas. And this is your portal to identify that. So we've not only seen cardiovascular or cardiometabolic conditions, but even neurologic conditions. There's a significant number of studies that have shown that through looking in the eye, we can identify early Alzheimer's, MS, Parkinson's, and that people are starting to look at this as ways to track progress. So there's a significant amount of information that could be gathered just by looking at the eye. And of course, ophthalmologic conditions. So this is something that we have now recognized could be an opportunity, but the problem is not so much the technology, but it's about workflow and reimbursement. Because this has been going around for a long time. I'd say, like, if I were to have given this lecture 10 years ago, I'd probably say the exact same things. But what's different? Well, what's different is in the past, when they did these studies, it took 20 minutes for a clinician to obtain the image. So you actually had a clinician come in, and so some cases, I'll use the very common one. They'd use a fundoscope, and they'd actually come in and they'd do this exam. It required 2 images per eye, and so when you did the first image, the pupil constricted, and then you'd have to wait 7 minutes till it dilated, and then you take the second image, and then you go to the second eye, and then you'd have to do the exact same thing. Now, if I use the fundoscope, 40% of the time I would need to dilate your eyes, so that means you wouldn't be able to then drive home. So a lot of people didn't like that. But in these studies, that's what they did. OCT came along, you do not need to dilate the eyes. On top of that, they automated the process, so rather than 20 minutes for this, it now is down to 2 minutes, fully automated, no clinician. So now what we've moved away from is requiring a clinician to be able to do data acquisition, image acquisition, and it's now fully automated. This is when we talk about, like, what's the role of agentic AI? It's to remove the fact that you're requiring a high valuable resource, a clinician, to acquire an image, and now you're using computers to do it. Now, the second thing is that the clinician also have to document that into the medical record. So that takes another 20 to 30 minutes to document. The same process can actually automate this down to 1 minute. So now you've actually got both the data acquisition, or the image acquisition, and the documentation all being done by the computer. And that is actually what's different about this initiative versus what we would have done maybe 20 years ago or 10 years ago when this was just being first studied. And so now what we are about to embark on, and this will happen next month, is an initiative to screen the entire US population, leveraging the fact that we can put these devices into different settings. And there's going to be 5 settings that we're focusing on. The first is eye care, which is already where a lot of these machines are. But the second is moving it to primary care. So at Stanford, they've actually been doing this for a while. What they've done is they've moved these machines into primary care settings throughout multiple different areas, predominantly in like rural and underserved communities. And when a person goes for routine vital signs, what happens is they will actually get their eyes checked as part of the routine vital signs, and they're picking up disease. They're picking up diabetic retinopathy, cardiovascular disease, a whole bunch of other stuff. They're actually having a Stanford radiologist and or a fellow review these films or these images because there's a lot that the AI doesn't pick up. It picks up the diabetic retinopathy, but it doesn't pick up all the other stuff. And so now what they're doing is they're finding that this is something that could be deployed in multiple different settings. That is also been deployed in other settings throughout the entire country, and because of the CPT code, it's now reimbursable, so this entire program actually is something that can be well supported, at least for the screening for diabetic retinopathy. So that's one of the settings, so moving from eye care to primary care. Another setting is retail, so retail clinics. Another setting is, I'll call it home-based settings. So a lot of people, whether in nursing homes or actually, one of the organizations it's close to here in Minneapolis has a bunch of physicians or nurses that go to nursing homes. These are individuals that oftentimes in nursing homes that have a hard time getting diabetic screening, and they're finding that this is something that can be done very easily. So nursing homes. And the last one is mobile vans. So really putting this into a van and going off and bringing it to other places. So you've got a lot of different new settings, and you have an opportunity to apply this in ways that have never been done before. The benefit from a clinical standpoint, and I'll go back to the Stanford example, is at Stanford, their screening rate, their HEDIS score for screening for diabetic retinopathy was 40%. So that doesn't mean that 40% of the time they were ordering it. They were ordering it 100% of the time. The score is based on the patient actually seeing the ophthalmologist. 40% of the time they do that. And here's what I think is one of the biggest learnings from this experience. Because when the message is, and you give this to patients, that it's the right thing to do. You have diabetes and you should get your eyes screened because it's something that is the right thing to do. Well, 40% of the time people will go that because they're busy, they've got other priorities. When you actually screen people and you say, well, we found something, and if you don't get treated, you're going to lose your vision in the next 2 years, everyone goes. So it went up to 80%. What's the difference? The difference is we've made it real. We've identified something. And the second thing is people put vision above all other health concerns. Why is it that? Anecdotally, when we talk to a lot of the folks, we've learned that people see vision as a means for them to be able to get a job, to maintain their job, to earn a living, to support their families. And if they go blind, they not only are a burden to themselves, but to their families. People think about priorities based on how it impacts the people they care about, more so than themselves. And so this whole concept of how do you change the paradigm for screening, which is traditionally getting people to do things which are good for their health, to now something that needs to be done for other folks, is something that we've come to realize. So let me kind of jump back to this. In terms of clinical, we're starting to see tremendous opportunity. Now, one other thing that we also want to do is we want to be able to apply AI responsibly. And what does that mean? That means that we want to apply it into settings that where the models are tested on local data sets, that we're actually monitoring for outcomes. And so to do that, what we've done is we've actually been partnering with organizations that are now going to be able to try to do some of that on behalf of the health system. So rather than just simply saying, hey, these models were tested elsewhere, we want to test them in the local data sets and monitor. So that's the responsible AI piece. There's a data element to this because there's tons of data that's being captured. I mentioned that diabetic retinopathy and some of these areas are being investigated. We want to open these data sets up to researchers to build new models and test new models. And we want to tie them in manners that allow us to be able to connect to electronic health records in privacy-preserving manners so that we can build predictive models and we can anticipate that. And the last is that we want to be able to think about new models that will support this, specifically pulling in other stakeholders. I'm going to just quickly fly through a bunch of other examples because I know that I don't have a huge amount of time to cover all of these. But I gave an example with eye. We can do the exact same thing with looking at electronic health record data. There's a tremendous amount of variation in care, and we can find those variations in care by simply looking at ways that people are practicing medicine. So in the area of oncology, for instance, we know that patients with cancers should get biomarker testing on the cancers. We know that the treatments should be concordant with them. Doesn't happen consistently. And so what we're now realizing is that we have an opportunity to be able to identify those patients and bring them to care. When we talk about voice, we now can use voice as a biometric. And so this is extraordinary. I mean, looking to see whether or not a person's depressed, anxious, simply by looking, not the words they're saying, but how they're saying it. 30 seconds can allow us to be able to do this. This has been validated against existing screening tools. Moving away from asking people to fill out forms, just simply using these technologies. This has actually been doing, there's many sites across the country that are starting to do this. This is data from Intermountain. They're doing this not only for the patients, but also for the providers that they're concerned about burning out. We're finding that we can take these individuals, we can identify them and bring them to clinical trials, so the AI can be extremely valuable there. And we can rethink the concept of population health in terms of identifying disease, risk stratifying, because many of these individuals are being brought into systems that are overloaded. We need to think about how to risk stratify and unpack those systems, and then we need to think about how do we engage patients. And there's a whole system of partners that now can be done, that can be applied in each of these categories. I want to talk a bit about trustworthy AI. I touched on that very briefly, but this is an initiative that I think many organizations have been thinking about. They agree with it, but they don't necessarily have the tools and resources to do this at scale. And that's been one of the reasons why a group called the Trustworthy Responsible AI Network launched in the United States. There's about 50 plus health systems, small systems, very large systems, and they're looking to operationalize by creating the technologies or working with technology partners to be able to streamline many of this. They want to collaborate at the model level so they can study whether or not these models are actually working, so where everyone's monitoring, testing it the same way, and then hopefully allowing ways to subsidize and partner. And what we want to do is we want to be able to help organizations answer what AI is running in their system today. Have you tested it on local data sets? Are you monitoring it for drift? Are you looking at whether or not it's actually having an impact on outcomes? Are it impacting individuals disproportionately, or is there bias? And how are you streamlining the governance? So there's a lot more to it than that, but there's many systems and many tools. This is just a list of some of the tools that are available today that we can be incorporated in there. I think one that I'll call out is the ability to detect hallucinations using large language models. I don't even think people realize that that's possible, but these are technologies now that can be brought into the system. And the reason why this is particularly important that we collaborate is because it's not just the technology that leads to outcomes, it's actually how it's implemented. And so just to give you an idea, we've learned this before with CPOE or computerized provider order entry. If we look at, I'll use patient safety as an example. Every one of these colored dots on the right is an EHR system. There's actually no difference between the EHR systems in terms of their performance relative to quality and safety. But there is difference within each system based on how individual organizations implement it. And that is extremely important because it's the same concept for AI. AI will largely be based on how you implement it, not based as much on just the technology. I can give you multiple examples around that. As we democratize it, this is something that we feel very strongly at Microsoft. We do need to think about how these organizations build these systems, and particularly multimodal models will be extremely valuable. Different types of data sets, and allowing us to be able to do three things: identify risk, high, medium, and low, visualize that, cohort it so you understand which type of patients are likely to have certain outcomes, and then predict what the outcomes are. And AI can help us do that, but in order to do that, we actually need to think about how it's done at scale. And so one of the things that we're doing at Microsoft is we're trying to think about this concept of creating what we'll call out-of-the-box embedding models, which are basically helping to do some basic stuff. Like if I took an image, can you just tell me where the outlines are? Can you tell me what the organs are? That's a basic type of technology that every one of the models should be doing. There's no point of reinventing the wheel. Then what we can do is we can fine-tune it on certain data sets, which could be proprietary, and then we use the large language model as a query tool, as a general reasoner that queries that particular type of foundation model. It's not that we're using LLMs to solve the entire problem, but it's, again, combining these different assets together in a way that we can provide out-of-the-box starting model. And we've already done this. So this is a published study in Nature, working with Providence, which is a very large health system, 28 cancer centers, over 30,000 patients using pathology images. We've been able to create some out-of-the-box embedding models that allow us to predict gene mutations and cancer subtypes just by looking at a pathology image. And there's initiatives also underway that are allowing us to think about how these technologies can be applied in rural settings. And so there's a whole series of different initiatives that I unfortunately don't have time to get into, but let's just say that there's a significant amount of effort around collaboration. Okay,
I'm going to like move on to the last piece, and this is the last topic I just want to touch on. None of this matters if we don't have a workforce that is ready to deploy this. We heard earlier that there are some people that are talking about replacing, that AI is going to replace jobs. As an administrator, as a hospital leader, you have two choices. With all this AI that's advancing, you can think about how it's going to replace tasks and potentially jobs as one, and that's actually an easy path for most organizations. But the better path is how we augment care. And I'll give you an example. One of my colleagues shared this story, and he shared it publicly, so I can share this with you all. He said that his uncle came into an ER. He had severe abdominal pain, and he died in the ER. He had a burst aneurysm. He had a CAT scan that was actually showed the aneurysm, and it was in the queue to be read by a radiologist. If we could have applied AI on that image and other images and prioritize and put that to the top of the queue, we could potentially have had an impact. Now, this is theoretical, but I think the concept is very clear. We don't have enough radiologists, and we don't have enough radiologists at every single point in the workflow. Our goal is not to replace precious resources, but rather to augment the capabilities. And as soon as we can realize that there's value in doing that, we have an opportunity to change the way that we do the workforce. And there's a whole set of programs right now that are underway to help understand how to augment as opposed to replace. So that's all I have time for. I know that I've been given a certain amount of time, but I think I have a chat, fireside chat, so I might be able to come into more details on that.
Sure.
Okay.
So first of all, thank you. Oh my goodness. We actually don't have time for
Oh, we don't? Okay.
We don't.
Okay.
I'm sorry.
Okay.
I wanted to give you as much time
Okay.
as we could. Hopefully you will be at lunch so that, and during the breaks, so that if you are open to taking questions, people can ask
Absolutely.
you then. But I do want to share with you, like, such a big thank you. When we were putting together our list of just wish list speakers, Pinar said, okay, I have one person on my wish list, and it was you, David. And she said, do you think that he would ever say yes? And we're so honored that you joined us. You did say yes. You did not disappoint. Thank you. We hope that we can make your whole stay valuable, because I know that you're meeting with some other individuals from the university this afternoon, so that you can talk more about what we're doing, as well as skilling and reskilling. And we hope to have an ongoing relationship with you.
Thank you very much.
Thank you so much.